Hello, Dr. Shamila.
Dr. Shamila. Dr. Sharmila, you can hear us loud and clear?
I think you're on mute. You'll have to unmute yourself.
No, she's not on mute. Dr. Sharmila, we can't hear you.
Hello, can you hear me now?
Yes, now we can hear you loud and clear.
Okay, so I will use this speaker, then I'll take off this microphone. Okay, do you hear a lot of background noise?
No.
No, perfectly all right.
Okay, so because otherwise I could close my window here, I can hear. Shall I screen share and see if my screen share works?
Sure, ma'am.
Perfect.
Perfect.
So you are able to see it? Okay, hold on. So, okay, are you seeing my slides or are you seeing my key notes?
I'm seeing your title slide, the role of nuclear in evaluation of heart
Do you see
diseases.
my, do you see my next slide?
No, I don't.
Okay, perfect. So it's the right, just wanted to make sure it was the correct display. Okay, hopefully we are all set, ready to go.
Yes, just give us a couple of minutes, Dr. Sharmila. This is Dr. Hemant Telkar here.
Oh, yeah, sure. From my end.
Yeah, sure. That's right.
Thank you so much for changing that time.
Take a minute to welcome everyone. Then Dr. Nori will take over as the Vice President, and then they will invite you on the screen dais.
Okay. Thank you so much for changing the time. I really appreciate that.
No issues. Pleasure is ours.
How are you doing with the pandemic, ma'am?
I think everything is under control now. We do have, what shall I say? I think just last week they said that if you're vaccinated, you probably don't even need to use the mask.
The mask, right.
Yeah, so this is very different from, I don't know, I'm even afraid to ask you guys how are things.
We're barely managing to wriggle out of this. Maharashtra, Mumbai is still doing somewhat better. We've passed on the buck to Kavita ma'am now. They're in lockdown this week onwards.
Yeah, it's worse.
Scary. It's really scary when I hear
It is.
everyone has heard someone who's affected.
True indeed.
Yes.
It's crazy. Wow.
Day and night we are struggling for beds, oxygen, whatnot.
Yeah. At least what I'm hearing is people who are vaccinated are at least not getting it. Is that true?
They do get it, but the severity is lesser, and they all end up with mild diseases.
Yeah. So at least the doctors are protected to some extent.
Yes.
All of us, a majority of us are affected. Almost 70 to 80% of healthcare workers. Yeah. The places where we are seeing COVID patients. Even otherwise also, asymptomatic patients are.
Yeah.
Even Dr. Telkar got infected. Dr. Vikram Lele also was positive, admitted for a couple of weeks with a CRP of I don't know, like 200 or something.
Wow, that's scary.
Yeah, it is. But hopefully should be getting better, hopefully.
You are at work, Dr. Sharmila?
No, I'm actually in what do you call grant review session, so I could work from home today. I don't have to go to office.
In a few seconds, there will be Saraswati Vandan, and then I will welcome you all.
Do you guys have a little logo? I didn't realize that.
वरदे कामरूपिणी विद्यारम्भं करिष्यामि सिद्धिर्भवतु मे सदा पद्मपत्रविशालाक्षी पद्मकेसरवर्णिनी नित्यं पद्मालयां देवी सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा।
Good evening, everyone. I welcome you all to the 7th in the series of the monthly webinar series we have through IACI, where we pick a particular topic and have a 1 to 1.5 hours of discussion as well as talk from eminent speakers. Today's audience is a mix of cardiac imaging specialist and nuclear physician. Just to give a brief of what IACI is, it's a not-for-profit organization of 1,000+ life members of cardiac imaging specialists, which is founded by a passionate group of teachers whose sole aim was to just disseminate information in the interest of the right things being done to the patients when they sleep on the table. Today's topic is on the role of nuclear cardiology, given the today's era of cardiac CT and cardiac MR. Today, we have an esteemed speaker who is the current president of American Society of Nuclear Medicine, Dr. Sharmila Dorbala. Thank you, Dr. Sharmila, for giving us your time. Now, I invite Dr. Vijaya Bhaskar Nori, our Vice President of IACI and our co-founder member of IACI, to take over the proceeding.
Thank you, Hemant. Thank you very much, Dr. Sharmila, for accepting our offer and spending your time with us, valuable time with us. We'll be enlightened with your knowledge, and let's hope to meet regularly like this in most of the coming meetings. So, Dr. Sharmila Dorbala is you see on your screen, all of you, very what you call academic person, hailing from Hyderabad, the state. They're Director of Nuclear Cardiology, Brigham and Women's Hospital. Currently President of American Society of Nuclear Cardiologists. She has over 200 presentations, many books, and is considered an authority on imaging of amyloidosis. With this brief introduction of the most enlightened speaker, I request Dr. Kavita Reddy. Dr. Kavita was a close friend of mine and also of Sharmila to talk something about the today's topic and also share her experiences, what she has with Sharmila, and how is Sharmila associated with the nuclear cardiology. Thank you very much.
Thank you, Dr. Vijay, and I thank ICI team for giving me this opportunity to be with you this evening. And I welcome Sharmila for this enlightened topic to throw some light for the practicing radiologists and also some of the cardiologists who are interested in this. Nuclear cardiology is not new to nuclear medicine. It's almost more than 6-7 decades ago. We started doing nuclear cardiology indications and then applications in nuclear medicine. But what's new is nuclear cardiology amidst CT or MR indications of cardiology, because both share the same indications like in coronary artery disease for ischemic evaluation of ischemic heart disease and also for the evaluation of viability, and of course the recent topic being inflammatory cardiomyopathies and more recently on cardiac amyloidosis. So Dr. Sharmila has got enough experience and thought of the publication, scientific evidences with her to take you through this topic and then show you the role of nuclear medicine in cardiology amidst these imaging modalities. Over to Dr. Sharmila for your presentation.
Dr. Sharmila, I will invite Dr. Parag Alan, who is head consultant at the Theragnostic Division at Infinity Medical Center, Mumbai, who was also a founder head of Department of Nuclear Medicine of British Candy, who along with Dr. Bhaskar Nauri will co-moderate this session with Dr. Kavita. I invite
Welcome, ma'am. Welcome, ma'am. It's a pleasure to have you and to moderate a session amongst the esteemed audience. A couple of lines about Dr. Sharmila. One is she has a robust foundation of medical education from India, but as she moved to US, she herself, as well as the American Society of Nuclear Cardiology, started their journey together almost parallelly. And today, after a couple of decades later, now she heads the Nuclear Cardiology Society in US. So that speaks of her vast experience and deep connect with nuclear cardiology she has. She specializes, or her specific domains of interests are quantitative myocardial perfusion imaging and amyloidosis imaging. So I think with this brief introduction, we're ready for the presentation, ma'am.
Sorry, I'm just setting up. All right, perfect. Are you able to see my slides well?
Yes, ma'am.
And you can hear me. All right. Thank you so much for that kind introduction. I'm really happy to be amongst all of you here, friends, particularly Dr. Kavita. I know her personally and I've visited her multiple times in the past. And very, very happy to see that the field of cardiac imaging is growing and taking upon a bigger role even in India. So I am currently the Director of Nuclear Cardiology at Brigham and Women's Hospital in Boston and the immediate past president of ASNIC. I was the president in 2020. And I'm really delighted to be here and to present a little bit about the role of nuclear cardiology using a case-based approach. Sorry. As an overview, I'll start off with a little bit of overview background on ischemic heart disease, and then share with you 5 cases to make a case for nuclear cardiology. As we all know, ischemic heart disease remains the leading cause of mortality across the globe. And in this particular study, from the Global Burden of Diseases and from the American Heart Association heart disease stroke statistics, you can see that the ischemic heart disease rate of mortality in India is very similar to what you see in US and many other parts of the country. And the important thing is we do have a number of modalities to evaluate ischemic heart disease. In this particular study, nearly 208 patients underwent SPECT, SPECT-CT, PET-PET-CT, as well as invasive angiography with fractional flow reserve measurement. And in this particular study, they showed that if you look at the overall accuracy here, PET shown in orange had the highest accuracy, followed by PET-CT, And then you can see here SPECT, SPECT-CT, and CTA. So in order to detect ischemic heart disease, looks like PET may have a slightly higher advantage compared to SPECT as well as CT-based coronary angiography. SPECT has been around for nearly 50 years now, and we know that this is one of the most quantitative techniques in the evaluation of ischemic heart disease. So some stress scores are highly valuable in assessing risk of patients, and patients who have a low sum stress score, which is 0, have an excellent outcome over 5 years compared to those with mild, moderate, or severely abnormal sum stress score. In this particular study, looking at over 13,000 patients and using automatic interpretation of the scan using machine learning type approach, Dr. Piotr Slomka's group at Cedars-Sinai has shown that stress total perfusion deficit, this is a software-based evaluation, can nicely stratify risk. And using a machine learning algorithm, looking at computerized reading with quantitation and taking into account the clinical and stress parameters, they showed very nicely that the observed risk of major adverse cardiac events parallels very closely the machine learning compared to the visual approach. On top of this, we do know that there are some changes in the temporal trends of coronary artery disease. These are data from the US showing that if you look at the curves from 1950, cardiovascular disease mortality fortunately has been gradually declining. And you can see it is much reduced now because of advances in medical therapy, declines in smoking, high blood pressure, widespread use of medical therapy, including statins, and better treatments for acute coronary syndrome and for chronic ischemic heart disease. This has paralleled the imaging world, where you see that the number of abnormal SPECT shown in red and the number of ischemic SPECT shown in blue have declined over time. So why is this? There's one pathological study looking at carotid endarterectomy specimens, and these investigators have shown that when compared to 2002-2003, atheroma has changed. And it has changed such that you see that the proportion of lipids, macrophages, intraplaque hemorrhage, and calcification in the plaque has declined over the past decade. And this has been attributed variably due to better medical therapy, mostly related to statin use and plaque stabilization. The other change, we also know that not only do we see less of obstructive epicardial disease, but at the same time, we are seeing a greater prevalence of microvascular coronary disease. So in this particular study called the CORE-MICA study, almost 44% of individuals presenting with angina and going to the cath lab demonstrated objective evidence of microvascular dysfunction. What these investigators did was they stratified them using invasive measures into microvascular angina, vasospastic angina, or non-cardiac chest pain, and provided a very targeted therapy. In this particular study, they found that use of therapy based on characterization of microvascular dysfunction improved angina score and improved quality of life in these patients. Therefore, the summary is, as atherosclerosis is changing, imaging advances need to change and need to keep up with the natural history of coronary atherosclerosis so that we can better detect disease, better stratify risk, better improve the management of patients, and improve their long-term outlook. So looking at that, we want to start off with ischemic heart disease. So this is just a schematic showing the major epicardial coronaries on the surface of the heart and this wide array of microvessels that perfuse the heart muscle. The epicardial circulation has conventionally been well imaged either with invasive angiography or CT-based angiography, and perfusion defects on relative either SPECT or PET myocardial perfusion imaging typically relate to epicardial coronary narrowing. Fractional flow reserve is an invasive metric of obstructive coronary disease in the epicardial vessels. However, when you look at epicardial and microvascular, think myocardial flow reserve or coronary flow reserve is a useful metric. It is calculated as a ratio of stress myocardial blood flow over rest myocardial blood flow, and is beautifully imaged using positron emission tomography. So here's just a schematic showing how FFR, fractional flow reserve, is a vessel-based and a lesion-based metric which evaluates the epicardial coronaries. Coronary flow reserve is a metric that evaluates flow through the epicardial and the microvascular circulation. And positron emission tomography is widely available and has a major role in evaluating coronary microvascular dysfunction. So here's the first case. We have stress and rest N13 ammonia PET imaging. On the top is stress, short axis. Second row is rest, stress and rest. Polar plots. And this is just a quality control screen showing the overlay of the PET and the CT to show that this is appropriately aligned. And there is this lateral wall perfusion defect that looks like normal at rest and completely reversible. So reversible lateral wall perfusion defect in this particular patient. And here's the gated study. You can see on the top stress and at the bottom rest, really excellent contractility, 62% and 71% ejection fraction respectively. The other measure that you can get with positron emission tomography is myocardial flow reserve. These are the dynamic images showing the radiotracer transit through the right ventricle, then into the left ventricle, and eventually into the myocardium. So using kinetic modeling methods, we can calculate myocardial blood flow, both territorially as well as globally, in the LAD circumflex right coronary territory as well as global LV at rest, peak vasodilator stress, and calculate a ratio called the myocardial flow reserve. A normal myocardial flow reserve is more than 2, and if it's less than 1.5, it's considered severely abnormal. A normal peak stress myocardial blood flow is more than 2, and if it's less than 1.5, is considered severely abnormal. The other metric that you can evaluate with the hybrid PET CT scanners is calcium score. And this particular patient had an attenuation correction CT. So this is not a gated breath hold CT. This is a non-gated pre-tidal breathing, low dose CT obtained for attenuation correction, but yet you can see extensive calcification in the LAD, right coronary, as well as the left circumflex arteries. So to summarize, this patient was interpreted as obstructive coronary disease in the lateral wall, either diagonal or left circumflex, and flows diffusely reduced in all 3 territories and globally, suggesting diffuse microvascular dysfunction. So this patient went on to have angiography, and his cath showed an occluded right coronary artery, tight stenosis in the LAD and the diagonal, which was fixed by stenting, and a 60% narrowing in the left circumflex. So the moral of the story here is, although relative perfusion images can identify ischemic heart disease with a high degree of sensitivity, it may be somewhat limited at detecting the full extent of disease. And in this case, if I can go back, you'll see that perfusion images were abnormal only in the left circumflex territory, but you can look at the flow values, which showed that they were reduced in all 3 territories and globally reduced. So the lateral wall ischemia was associated with severe flow reduction in all territories. If the global CFR is MFR is less than 1.5 in the right clinical context, that could be considered an indication to proceed with coronary angiography. So in any case, so this was a patient where by using the combined information of relative and quantitative flow, we were able to arrive at a correct diagnosis of the most severe disease being lateral wall ischemia, likely from this diagonal, and also identified ischemia in the other vascular territories. As with SPECT perfusion imaging, quantitative PET imaging with some stress scores or person myocardium ischemic can identify risk of future cardiovascular events. Normal scan, mild, moderate, or severely abnormal scans are associated with an increasing hazard of cardiac death, and they appear to provide incremental risk stratification when compared to baseline clinical metrics in these patients. As I showed with the invasive angiography study, this is a PET study data from our lab in nearly 1,200 patients, all of whom had normal perfusion PET studies. We found that coronary flow reserve was abnormal, shown in this red here, less than 2. in about 54% of women and 51% of men, and very similar distribution. And we also found that despite the fact that these patients had normal perfusion, those who had a coronary flow reserve less than 2 had a higher event rate of major adverse cardiac events, both in men and in women. Moreover, we also found that independent of perfusion defect severity, no defects, mild to moderate defects, or severe defects, this being the percent myocardium abnormal here, you'll see that patients with the lowest tertile of coronary flow reserve, shown in this bright orange here, have much higher event rates. A very similar data from Kansas City showing in nearly 12,000 patients that patients with a myocardial blood flow reserve of less than 1.8 have a much higher risk of mortality compared to patients with a myocardial flow reserve of more than 2. The biggest added value of flow in ischemic heart disease appears to be when the flow is preserved. So this is data from Ottawa Heart Institution, and on the right side from our institution, Brigham and Women's, showing that as the myocardial flow reserve decreases, the probability of 3-vessel coronary disease increases. And the same thing here. However, if you look at a flow reserve of 1, which essentially tells you that the flow at rest is equal to flow at stress, you'll notice that the probability of multi-vessel disease is only 50%. So again, keeping in mind that when the flow is preserved, when the myocardial flow reserve is more than 2, the probability of missing significant obstructive coronary disease is very low. But when the flow reserve is abnormal, then it could represent either microvascular or epicardial obstructive disease. Therefore, the best value of flow at this point appears to be when the flow is preserved, we can be very confident in saying that this patient is unlikely to have severe obstructive multivessel coronary disease. Flow also has been shown to have value in guiding response to therapy. Data from our lab again, looking at different categories. Coronary flow reserve high with no revascularization, percutaneous intervention, bypass surgery. Coronary flow reserve low, no revascularization, percutaneous or bypass surgery. And what we notice is that when you look at high CFR, no revasc versus CABG, there's no statistical significant difference, even with PCI. Whereas in this cohort where the CFR is low, particularly you can see that there is a significant difference with bypass surgery for complete revascularization as opposed to PCI. So the data like this suggests that flow may potentially be a useful metric to guide which patients may benefit from surgical and complete coronary revascularization. So why is all of this relevant? It's relevant because although PET is not widely available, SPECT is widely available in clinical practice, and it remains the backbone of most nuclear cardiology practices worldwide. The prevalence of microvascular disease is increasing, and advanced SPECT technology and software now make it possible for not only low radiation dose imaging, but also quantitative myocardial blood flow imaging. So this is the much needed translation in our field, data from 2013 from a group of investigators showing that quantitation of myocardial perfusion reserve is feasible using CZT type scanners, spectrum dynamic scanner in this case. A more recent study in 2018 using a GE type of CZT scanner validated SPECT perfusion imaging quantitative flow in relation to O15 labeled PET and fractional flow reserve measurements. In this particular study, the key finding was that flow values were slightly overestimated with SPECT compared to PET. However, what we'll notice is that they were correlated, and flow reserve, the ratio of stress myocardial blood flow divided by rest myocardial blood flow, was highly accurate in identifying obstructive disease using invasive FFR as a threshold. So because of this, we believe that the use of flow and flow reserve is likely going to increase in clinical practice. So next case, sarcoidosis. A 49-year-old African-American man with a lymph node biopsy-proven sarcoidosis comes in for evaluation of syncope. Most of his testing was negative, and the question was, because he had systemic sarcoid and he had a syncope, could he have cardiac involvement? So the first test, most of the times in these cases, is cardiac MRI with gadolinium contrast. So he underwent a cardiac MR with gadolinium contrast with T1 mapping, and it was completely normal. No late gadolinium enhancement. His function was normal, and his edema imaging showed no evidence of myocardial edema. So what do you do next? Okay, so the question is, at this point, are we happy that he has no cardiac sarcoidosis? Should we be doing any further imaging? So the clinical team was highly suspicious of syncope related to cardiac sarcoid in this case, and they wanted to proceed with FDG. So this is our FDG protocol for sarcoid: 1 day of preparation, followed by perfusion imaging, cardiac FDG, and partial body FDG imaging. The preparation is mostly comprised of a ketogenic diet, followed by 8 to 12 hours of fasting, and rest perfusion with attenuation correction, either SPECT-CT or PET perfusion imaging, cardiac FDG, and partial body FDG imaging. So this patient underwent the study, sestamivi images on the top, FDG images on the bottom. You can see focal lateral wall uptake, partial body images show mediastinal uptake, suggesting systemic disease activity. So the question at this point was, should we give this patient an ICD or should we go ahead with an EP study, because now he has focal uptake in the lateral wall? So this is one of the challenging areas for FDG, lateral wall uptake, particularly in the absence of LGE on MRI, as in this case, in the absence of perfusion defects, could sometimes represent physiological glucose utilization. The lateral wall somehow is hard to suppress many times. So this was still not clear in our mind that this was a definite indication for ICD. So we discussed with this with the patient's referring team. They decided to watch him and bring him back for a repeat study. The repeat study several months later showed very similar perfusion images. No longer was there any uptake in the myocardium. He still had the systemic activity. So at this point, they decided to manage him conservatively without any further ICD implantation. So what are the classic findings of FDG PET on sarcoidosis? You see these focal granulomas. They can affect the left ventricle or the right ventricle. Usually they coexist with systemic disease activity. They can show response to therapy. So FDG is not only helpful to make a diagnosis, but can be extremely helpful to evaluate response to therapy. Classic MRI features: late gadolinium enhancement, focal myocardial thickening. This LGE can be subendocardial, mid-myocardial, or epicardial. Classic patterns. For some reason, edema imaging is not strongly positive in cardiac sarcoidosis. So just the fact that somebody does not have edema does not exclude sarcoid, and also the fact that someone does not have LGE may not exclude active sarcoid in early disease. Most importantly, I feel the advantage of molecular imaging with FDG is that LGE can represent expansion of the extracellular space, either related to inflammation or related to fibrosis. So whether or not you treat a patient for sarcoidosis using immunosuppressive therapy, that decision is best made in the context of FDG imaging. So at our lab, although MR is the first test for sarcoid, if MR is positive, we always proceed with FDG before initiation of therapy, and FDG is the test of choice for follow-up. These are data showing that the diagnostic accuracy of FDG is high, and patients with both normal perfusion and normal FDG uptake, shown in green, have good survival, excellent survival, free of death or VT. Patients with both abnormal perfusion and LGE have much worse survival. If either one of them is abnormal, it's intermediate survival. So the next case is one of infective endocarditis. A 54-year-old man with bicuspid aortic valve underwent aortic valve replacement and ascending aortic root replacement. He presents with transient vision loss and blood cultures showing Cardiobacterium valvarium. So here's his TEE showing a little something on the aortic valve, FTG imaging using the ketogenic diet prep, intense focal uptake. And when we did the whole body imaging, we could see multiple embolic phenomena to both feet and a splenic infarct, this dark area here. We routinely perform contrast CT for all our infective endocarditis cases. Contrast CT shows this ascending aortic involvement. And when you focus that, when you overlay that with the FDG, you can see it corresponds to an area of inflammation right around that area. So the huge advantage of adding CT to FDG is that CT provides structural information, whereas FDG tells us whether or not there is inflammation or infection in this particular area of CT abnormality. So our patient met two major criteria, and definite infective endocarditis was diagnosed based on the modified Duke criteria. So the ESC guidelines recently added abnormal FDG activity and definite paravalvular lesions by CT as imaging criteria for infective endocarditis. And if you look at the ESC algorithm, it says that in patients with prosthetic valves, FDG, PET-CT, or leukocyte scintigraphy and cardiac CT may be considered if the modified Duke criteria suggest possible or rejected infective endocarditis but high clinical suspicion. So our patient already met criteria for infective endocarditis. So the question is, why did we perform FDG PET as well as CT-based coronary angiography in this patient? And this is a study from Spain looking at 72 patients with suspected infective endocarditis. And what they showed was Duke criteria leave us with nearly 50% of possible infective endocarditis. When you add FDG with PET-CT without contrast, this 54% goes down to 20%. When you add FDG plus contrast enhanced CT angiography, that further gets reclassified and the possible endocarditis shrinks to only 8%. So the addition of contrast CT appears to significantly reclassify definite endocarditis, either diagnosed or excluded, and reduces uncertainty. So the diagnostic accuracy of FDG has been studied by multiple groups. One meta-analysis shows that it is not as accurate for native valve endocarditis, whose pooled sensitivity 0.31, specificity of 0.96. The major role of FDG PET appears to be in prosthetic valve endocarditis and cardiac implantable electronic devices, pacemakers and ICDs, where the accuracy is much higher. Next case is vasculitis. FDG PET can be used to assess inflammation in the major blood vessels in vasculitis. Here's a 47-year-old without cardiac risk factors presenting in 2005 with chest discomfort precipitated by emotional stress. He underwent a number of tests, including a contrast CT study. And here you can see this thickening around the aorta on the axial images as well as in the long axis images. This patient was then referred for FDG PET. And here you can see circumferential uptake of FDG. The suppression, myocardial suppression was not great. However, since our question was aorta, this study was still interpretable. Patient was treated with high-dose steroids and immunosuppressive regimen, comes back 6 months later. CT abnormalities still persist. You can see the axial and long axis images, whereas FDG images demonstrate resolution of active inflammation. In vasculitis, what we know is that both structural abnormalities of vasculitis, whether it's CT or MR angiography, are useful first tests to identify the presence of possible vasculitis. FDG PET, however, is much superior at evaluating whether or not is baseline inflammation and may turn out to be better than structural imaging to look at response to therapy. So there were guidelines on vasculitis imaging published by the EANM in conjunction with other societies. And what they recommend is CTA and FDG PET have complementary roles in evaluation of large vessel vasculitis, and CTA has incremental value in detecting structural vascular changes and potential complications. FDG cannot image structure, so it's highly unlikely that FDG alone could be useful in vasculitis, so you need some form of angiography. However, for the response to therapy, they made a statement that FDG PET may be of value for evaluating response to treatment by monitoring functional information and detecting structural changes, but additional studies are warranted. So this is an area of active ongoing interest and research. We need to understand how best to utilize the combination of techniques. So the last case I want to share with you is an amyloidosis case. Here's an example of a 76-year-old man with heart failure with preserved ejection fraction and well-controlled high blood pressure. Echo from 2011 shows a wall thickness of 12 millimeters with normal function. In 2018, the wall thickness increased to 16 millimeters, still has a normal function. But at this point, the question was, why did this man with well-controlled high blood pressure develop increased wall thickness? So his physician was concerned that this could represent a secondary pathology such as wild-type ATTR amyloidosis, and he was referred for a PYP SPECT CT scan. Here's PYP SPECT CT overlay showing grade 3 myocardial uptake of technetium-99m pyrophosphate, confirming that this is likely amyloidosis. So in this patient, further evaluation for light chain amyloidosis was completely negative, confirming that this is most likely wild-type TTR of aging, and he was initiated on therapy with tafamidis. So what is cardiac amyloidosis? It's a protein misfolding disorder where misfolded proteins deposit as amyloid fibrils in the various organs. They come in two flavors: immunoglobulin light chain amyloidosis, which is a plasma cell dyscrasia, and transthyretin amyloidosis, which is the most common form of amyloidosis, tends to affect the elderly unless it is a mutated TTR in the inherited form or hereditary TTR, which can affect younger individuals. The most common clinical manifestation is heart failure with preserved ejection fraction with varying degrees of autonomic neuropathy and other complications in the hereditary disease. So in amyloidosis, what are our imaging targets and what are we imaging? So here's a normal heart schematic with cardiomyocytes in extracellular space. The heart muscle can thicken either from true muscle hypertrophy, as in high blood pressure or increased afterload from aortic stenosis, or it can thicken from infiltration. Infiltration by amyloid fibrils, which affects both ventricles typically. And this increased wall thickness can be beautifully imaged by echocardiography or magnetic resonance imaging. The expanded extracellular space can be quantified using gadolinium-enhanced cardiac MR T1 mapping techniques. Wall thickness increase is not specific for amyloid, whereas expanded ECV and characteristic gadolinium kinetics can more specifically identify and distinguish amyloid from non-amyloid hearts. However, echo and MR are not helpful at separating AL from ATTR cardiac amyloidosis. The most direct and specific imaging of amyloid fibrils is with radionuclide tracers. We have a number of PET compounds developed for Alzheimer's imaging, as well as a number of SPECT compounds, most widely used being bone-avid tracers, pyrophosphate DPD and HMDP. In a large multi-center study from 8 major amyloidosis centers from 5 countries, nearly 1,400 patients and nearly 400 with endomyocardial biopsy underwent bone-avid scintigraphy. So in this particular study, grade 2 or grade 3 PYP uptake in the absence of a clonal AL process was nearly 100% specific for ATTR cardiac amyloidosis. However, if you look at any grade positivity and do not exclude AL amyloidosis, you'll notice that the specificity falls to 78%. So multiple societies got together and tried to define the standardized imaging characteristics or standardized imaging procedures for cardiac amyloid imaging, and also try to develop diagnostic criteria and appropriate utilization of this technique. The experts in this document, which was led by the American Society of Nuclear Cardiology, said that you could have two pathways to diagnosis. One is biopsy, endomyocardial biopsy, or extracardiac biopsy plus typical imaging features on the heart, either by echo or MR for AL-ATTR, extracardiac biopsy with cardiac biomarkers for AL. A non-biopsy pathway is also possible. You have grade 2, grade 3 PYP uptake, you exclude a clonal process, and you have typical cardiac imaging features, then this is sufficient to make a definitive diagnosis of ATTR cardiac amyloidosis. Remember, MDP, which is used in some of the countries for bone scanning, does not exclude amyloidosis. So here's a negative bone scan in a patient with typical symptoms and imaging features of amyloidosis. So this patient, MRI, showed wall thickening, biatrial enlargement, all other features. Based on this, we referred the patient for PYP, despite a negative MDP scan. Again, grade 3 PYP uptake confirming coexistent TTR amyloidosis in this patient with prostate cancer and HFpEF. So how do we grade PYP? Grade 0 is no myocardial uptake. Grade 1 myocardial uptake less than rib. Grade 2 myocardial uptake equal to rib. Grade 3 myocardial uptake greater than rib. SPECT-CT, when available, can be extremely helpful in separating myocardial from blood pool activity. SPECT is essential. Planar imaging alone is not sufficient. Most importantly, there's emerging data from multiple institutions looking at quantitative SPECT metrics. And the next frontier in cardiac amyloidosis imaging with bone-avid scintigraphy is likely going to be quantitation using SUV-based metrics, total cardiac amyloid activity, percent injected dose, volumetric measures. So these metrics, we believe, may be extremely helpful in making early diagnosis, possibly even identifying response to therapy. So what are the key takeaway points in amyloidosis? Think of amyloidosis so you don't miss it. In patients with heart failure, increased wall thickness, red flag signs, neuropathy, and mutations. Grade 2, 3 PYP uptake, if AL is excluded, can be highly specific. Remember the pitfalls, blood pool activity. So delayed imaging and SPECT is important. AL needs to be excluded. AL patients may have any grade PYP uptake, grade 0, 1, 2, or 3. Therefore, if you suspect amyloidosis based on echo or MR, if the PYP is independent of the PYP findings, you need to proceed with AL evaluation because that's a medical emergency and needs to be treated right away. Certain hereditary forms of TTR may have low sensitivity with bone-avid tracer scintigraphy, and MDP is not adequate for PYP imaging. So to summarize, nuclear cardiology in this era of CT-MR, I believe is a really powerful tool to phenotype cardiovascular metabolism and physiology. To think of the fundamental basis of disease, looking at alterations of genes, related proteins, metabolic changes, physiologic changes, and anatomic changes, we know that disease with anatomic changes may have feedback loops and alter metabolic and physiological processes. So there is a continuous feedback loop, and nuclear cardiology has a major role in evaluating myocardial and cardiovascular metabolism and pathophysiology. Because of this, I believe this technique will remain the future of evaluation of cardiovascular diseases and play a major role in precision medicine type of applications. Although I discussed certain applications today, given the time limitations, ischemic heart disease, amyloidosis, infective endocarditis, and sarcoidosis, there are a number of other emerging applications, including evaluation of microcalcification, denervation, applications in cardio-oncology that can be extremely helpful in these patients. Thank you very much for your attention, and I'm happy to take any questions.
Thank you, ma'am, for a wonderful session. It's always so enlightening to listen. And every time I do take home at least 2 or 3 new teaching points that I wasn't aware of. So a couple of quick questions, ma'am. Do you also do CT-based FFR in your institute? If so, how has your experience been with that?
Yeah, that's an excellent question. Believe it or not, we are still working on this. We don't have access to it right now, not because we don't have access. The images have to be sent for measurements, but we don't have institutional agreements in place. So basically, I know that from other institutions, you send the images out to the company and they will send us back the FFR results very shortly. It seems to work well at the extremes where it's negative or where it is obstructive, but the intermediate lesions where it's most helpful, there could be variability in FFR based on some of the other studies that have used the FFR measurements from CT. So this is an evolving area and probably an interesting area where you could look at anatomy and physiology together, but we need more data in the intermediate lesions where we believe flow quantitation is going to be most helpful.
Right, ma'am. Also, the current data for CT-FFR, I think, is largely limited to stable ischemic heart disease and not in infarcted or ischemic patients already. And second thing, ma'am, with cardiac amyloidosis, what would be the first preferred modality? Would you do an MR first, and if MR is positive, only then do you do a PYP SPECT, or how do you sequence the imaging modalities?
Yeah, that's an interesting question. Again, it really depends on the suspicion and the type of disease. So usually by the time there's a suspected amyloidosis, these patients have already had an echocardiogram for sure, probably an MR in some cases. So the next step could be based on what is a suspicion. So basically, if it is an older individual where the suspicion is for wild type TTR cardiac amyloidosis, then in those patients, after an echocardiogram, we may proceed straight away with a bone avid scintigraphy. Whereas in younger individuals where we are not clear whether this is AL or ATTR, and in individuals where the AL evaluation is not negative. So it may not indicate AL amyloidosis, but there's some abnormalities in the serum free light chain assays. And in some of the older patients where you may have abnormalities like MGUS, in some of those patients, MRI could be the initial test. So it really is a case-by-case evaluation. And the way I said for sarcoid, we start with MR and then use FDG for follow-up. With amyloid, I think it may be the other way around, which is right now we believe we could start with PYP for wild-type TTR, but for follow-up, PYP imaging does not provide structural information. So to look at changes in structure, there's some data to suggest that ECG may be changing with treatment, and MR may be more useful for follow-up. But we have to wait and see whether the PET tracers add to response to therapy, whether quantitative SPECT tracers can also add. So I think it really is, again, case by case.
Right, that's quite clear. Anybody else has any questions to ask?
Yeah, Parag, I'll just have one doubt with Dr. Sharma.
Sure.
Dr. Sharmila, that was a fantastic presentation. We learned a lot from it. I just wanted to ask you regarding the first case on the myocardial perfusion, flow reserve.
Yeah.
In the first case, where the stenosis was very severe in RCA and LAD, but it was moderate 60% in circumflexury. But that territory had an ischemia, if I am right. So, was a catheter-based FFR done for that? Number one. Number two, catheter-based FFR also is known to give the same answers, where a 90% lesion would not have critical ischemia, but a 50-60% lesion would have a critical ischemia. That is where the FFR has changed the entire gamut of the intervention. So, how do we expect this flow reserve changes versus FFR in a 60% lesion and not in an 80 or 90% lesion?
Yeah, that's an excellent question. So the lateral wall is an overlap territory. It could be either diagonal or circumflex. In this particular patient, it was a 90+% diagonal stenosis. So that's why I think it corresponds to that area of ischemia. That is the most severe. In terms of FFR with catheter-based, first of all, it adds extra time. It's an interventional procedure. It adds extra time. And some lesions cannot be easily studied, particularly total occlusions, for example. And if they're serial lesions, and if they're lesions in multiple vessels, FFR has to be performed for each lesion within LAD and for each lesion within the LAD circ and RCA. Whereas with PET, you can non-invasively get this information. And not only do you get information about FFR, which is epicardial disease, but you can also get information about microvascular perfusion. So the combination of two can be performed non-invasively, which can maybe avoid the need for invasive angiography in some of these patients for diagnostic reasons.
Thank you very much. One quick question. What is the role of MRI PET in cardiac imaging?
PET MR, the combined. Yeah, that's an excellent question. I think PET MR is extremely helpful when you want to study two physiological processes at the same time, as in some of the neuro applications, or when you want to study small structures like carotid or coronary atherosclerosis, where PET MR can be useful because it can provide for motion correction, respiratory motion correction of the PET image. And there is inherent co-registration of the PET and MR with small structures. Whereas PET CT, you still have two sequential images, so co-registration is not perfect. So I think it still remains, what do you call, a research tool at this point. For some of the clinical problems like sarcoidosis, I personally, we don't have experience with PET-MR, but I can't see any logical reason why PET-MR, simultaneous PET-MR could be helpful. Usually we proceed from one to the other, and since co-localization is not that critical, it's not particularly helpful in my opinion for clinical practice.
Thank you very much.
There's one question from the audience, ma'am. It says, with limited availability of PET perfusion, how does SPECT compare with stress cardiac MR perfusion in your experience?
Yeah, so the few papers that are published on this topic appear to show that MR perfusion is equivalent in accuracy, similar in accuracy to PET perfusion. So SPECT perfusion appears to be a little lower in terms of accuracy compared to MR and compared to PET. However, this is all old data, so we need to see if the newer techniques, particularly the CZT scanners and particularly flow quantitation with CZT, have made any impact or change for this particular technology.
There were a couple of questions by Dr. Rajesh and Dr. Vimal. Do you think you want to bring it up on the DAS?
I see one question here, which is CMR negative sarcoid but PET positive. What is likely underlying pathophysiological process, inflammation, scar, or something else? This is a very important question because FDG PET is not specific for inflammation. FDG uptake can be physiological, can indicate inflammation, infection, or even ischemia for that matter. So if CMR is completely negative and PET is positive, which is the case that I showed you, what we found in one of the autopsy-based studies is that it's a non-specific finding, particularly if it affects the lateral wall. If we find focal FDG uptake in the anteroseptal wall, infroseptal wall at the base, or infralateral wall, focal, then we believe it's more likely to represent focal inflammation. But if it's the entire lateral wall at the base, in the absence of CMR abnormalities, it is a reduced, that finding has low specificity for focal inflammation, and it could represent, as we showed in one paper, even ARVC. It could represent other forms of cardiomyopathy, where your FDG uptake may be abnormal.
Just to add, ma'am, at Just Look, we have often noticed this uptake being localized to the thicker papillary muscle inserted over the posterolateral free wall. So perhaps that will be one of the reasons.
Yeah, so the papillary muscle uptake, I believe, represents really high resolution imaging. It really tells you, when you're seeing the papillary muscle, it really tells you that your PET scanner is performing at a high level and you're getting exquisite image resolution to resolve the papillary muscle.
All right.
I just want to add one more thing, because the question says that it's inflammation or scar. Unlike MR, which enhances, where you see enhancement in scar, FTG will never go into scar or fibrosis. That much we can rule out, that it's not a scar if there is any FTG uptake.
Dr. Kavita, could you repeat that? You were a bit on the lower side of the volume. Could you just repeat the whole thing again, please?
The question says whether it's inflammation or scar. So if FDG is there, it is not a scar. Like in MR, delayed contrast enhancement, you can get fibrosis also, but scar or fibrosis. But if FDG goes there, it's not a scar. It's a living tissue. So that is very specific.
Excellent. I fully agree with Dr. Kavita. I think that's a good point. If MR shows late gadolinium enhancement and the PET shows FDG uptake, then that represents most likely some component of inflammation there. It's not fibrosis, because usually when people think of LGE on MR, thinking fibrosis. So in sarcoidosis, the LGE may represent some component of fibrosis possibly, but with inflammation. And if FDG is positive, I agree, it's likely to be inflammation.
There's one more question on the chat box. Any importance of atrial uptake on PET CT in sarcoid or other conditions, or it is as non-specific as contrast MR, late gadolinium enhancement of atria?
Yeah, this is a very good question. We have noticed, first of all, one good point, which is always look at the fusion images of CT and FDG, because right ventricular FDG uptake, which is a poor prognostic factor, cannot be seen in the classic cardiac projections, the short axis, vertical and horizontal long axis. You may miss it. So look at the fusion images, look at the whole body images to identify right ventricular uptake. We have seen atrial uptake and others as well. A lot of people have described this with atrial fibrillation. For example, patients with AFib tend to have atrial uptake. The other area when we've seen atrial uptake is patients with significant LV dysfunction, where they have cardiomyopathy. That is another area. I don't know if it represents sarcoid granulomas per se. It could. Sarcoid granulomas can go to the atria and it could represent sarcoid granuloma as well, but there could be other reasons.
Yeah, myself, Dr. Rajesh Kannan from Kochi. So very nice presentation, Dr. Samila. So just a few comments now regarding the sarcoidosis and PET-MR. Since we have PET-MR for the last 2 years and we have some experience in cardiac sarcoidosis. So what we seen in a few cases, what we have done is we didn't see any cases where only PET is positive and the MRI is negative. But what we have seen is even in MRI positive cases, by looking at the PET scan and retrospectively, we could able to pick up much more small scars, which otherwise could have been missed. So far we didn't see any case where completely normal MR with the positive PET, but because the PET MR that is simultaneous PET MRI, where the registration is much better, your confidence level will be very high wherever there is an uptake. And if you look very carefully, the scar many times what is the enhancement, what the undelayed enhancement scan LGE may be relatively subtle, but we could able to pick it up because there was an PET uptake. That is one thing. And the second case, as you rightly pointed out, the MRI sometimes it's difficult to differentiate an active lesion from a healed fibrosis. which is very important in management point of view, because wherever there is a PET uptake, that usually indicative of an active lesion, and the giving a steroid or other anti-inflammatory medicines will be very helpful. Whereas if it is just fibrosis, then the anti-inflammatory drugs may not work out. So probably they may need another form of therapy. So to decide on that, PET will be really helpful. And we have seen a lot of cases where MRI is positive, showing lot of fibrosis, but there is no uptake. So which indicate that they are all just a fibrosis. There is no active inflammation, or there is no active granuloma. Thank you.
Excellent points. I actually agree with most of them, except that I can tell you that we are not using PET-MR, but are on sequential. I fully agree, which is why I think MR cannot distinguish active inflammation from fibrosis. So if the MR is strongly positive for sarcoid, we still need to do a baseline FDG pre-treatment. And FDG is used for post-treatment as well. I just wanted to share one case with you. I don't know if you're able to see my screen or not. Are you able to see my screen?
Yes.
Yes.
Yes. Yes.
Yeah, so this is a case where we started with MRI, okay? 53-year-old with traumatic syncope. ECG showed significant conduction system disease. Lyme, ANA, babesiosis, everything was negative. But look at the ECG. He has a lot of heart block. So if you look at previous literature, in young people presenting with unexplained AV block, nearly 30% have undiagnosed sarcoid. And in patients with sarcoidosis with AV block and EF that's preserved, the rate of sudden death can be nearly 10%. So this particular patient went on to have an MRI, which was completely negative, completely negative. I couldn't find the images right now, but here's his FDG image. Okay, because of the high suspicion, we proceeded with the FDG. You can look at systemic activity. MRI is unlikely to pick up systemic sarcoidosis because you focus on the heart. So you can see systemic activity, and then look at this focal activity in the basal interventricular septum. If this was lateral, I would worry about non-specific uptake, but this is basal septum, and this patient had an endomyocardial, endobronchial ultrasound with biopsy that revealed granulomas consistent with sarcoidosis. So this is just one case that I'm able to show, but we've had at least a couple of other cases where the MRI was completely negative and FDG was positive. So I'm not saying it's a common problem, but in the right clinical context, if you really are highly suspicious, those are the few cases where you may want to proceed with FDG. This is not routine. This is not routine.
Rajesh, I just have one question for Rajesh and Sharmila. Regarding the sarcoidosis itself, MR and PET, Rajesh was telling that fibrosis versus inflammation is difficult to make out with LGE, but that is why the T1 mapping has come up, and T2 mapping, T1, T2 mapping has come up. Rajesh, what is the experience in differentiating between inflammation and fibrosis with T1 mapping?
I think T1 mapping may not differentiate, because in both the cases it's going to be high. So T2 mapping supposed to show the T2 mapping which is more specific for edema, which supposed to be more specific of an active disease. Generally it should not be high in a healed granuloma. But in those cases, I didn't find that much useful, even T2 mapping. So as compared to the PET, so PET was much better in differentiating these two. And one more point as I want to highlight is where MRI can go wrong is the delayed enhancement. Even though we are saying is very accurate, sometimes if you don't do a volume scanning, in a PET scan, it's a volume scan. Whereas in a MRI, what we are doing is we are taking usually one short axis, I mean one 2-chamber, one 4-chamber, and say 6 to 8 short axis. And one of the major problem is at the basal level, where sometimes we will misinterpret that partial volume with the cavity as an enhancement, and we'll think that there may be a small scar, but we may think that is just a partial volume. So that is one area where MRI may miss, and the PET can scores.
Yeah,
Thank you,
I
Rajesh.
fully agree about the volume acquisition, and the basal septum can be challenging also for PET perfusion, because we always think it's septal, membranous septum and septal dropout. And there are cases where on the perfusion, we would not read a perfusion defect, but FTG shows focal uptake in the basal septum, and MRI can show LGE there. So the basal area could be challenging even for perfusion and FTG.
Thank you, Rajesh and Sharmila.
Thank you all. I think it was a wonderful session. Thank you, Sharmila, for a wonderful input, sharing your experience with us at IACI. Before we end, a small screenshot photo session. Can all the panelists switch on their video camera so that we can have a screenshot of today's panelist? Thank you. Thank you again all for your time and efforts. Thank you, Priya, for being the team leader behind this whole webinar series. And next session for the monthly webinar will be on congenital portosystemic shunts, an often missed entity. And this will be presented by the team from Ahmedabad, from UN Mehta Institute of Cardiology and Research Center. Till then, we see you.
Thank you all. Bye.
Thank you so much. Bye-bye.
Thank you. Bye.